I'm Joseph Albert, editor-in-chief of the American Journal of Medicine, and I'm with you again this month to call attention to an article in this month's issue that I thought was particularly interesting. The first author was Duras, but there was a large collection of international authors, mostly from Europe, but some from Canada, in which they looked at a number of huge databases, the ones from Quebec, the one from Germany, and other places, put them all together and looked at the patients who had received warfarin type anticoagulation for deep venous thrombosis versus people who've gotten one of the new direct oral anticoagulants, the DOACs. As you know, there have been many trials, double-blind, excellent randomized trials, showing generally that they're equally effective if you do a good job with warfarin, with monitoring the warfarin. But a number of the trials show the DOACs were a little better with a little less bleeding complications. And of course, that's because the warfarin related anticoagulation sometimes sneaks out of control in between monitoring sessions. In any case, they pulled this huge database and controlled for a whole bunch of different factors and found there was no difference between the outcomes, bleeding or complications or efficacy with the DOACs and warfarin. But again, each of these countries have national health services, so their INR follow-up is really meticulously done. Holland, for example, 80+ people are in range with the INR, whereas the average in the US, where we don't have that amount of coverage, is only about 50 to 60%. But in any case, it did say that warfarin is still a viable option, but you got to do it right. You can't just hand it out and then tell patients come back in a year. So I hope you'll read this article. It's interesting. We still put a lot of patients on warfarin when the cost of the new DOAC is excessive. So please follow us on all of our social media venues, and I look forward to being with you again next month.